Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner certified in Ayurveda and functional medicine. And today we have a guest that I'm excited to introduce, partly because of what he knows and partly because of what he's going to talk to us about, which is actually the topic of neuropathy. Very painful, uncomfortable condition. We see a lot of it in our clinic. And he's got some innovative treatments to share with us that we are now doing locally. So Dr. Dan Olesnicky is a diplomat of the American Board of Internal Medicine, the American Board of Emergency Medicine, and the American Board of Tactical Medicine. In addition to running one of the largest regenerative and pain medicine practices in the Coachella Valley, Dr. Olesnicky also serves as a SWAT team physician and police officer in Palm Springs, California. Because of his unique background and wide array of engagement within the Coachella Valley, Dr. Olesnicky sees a wide range of patients and is highly regarded as a teacher and trainer in the medical community. Dr. Olesnicky, welcome. We're so glad to have you.
Outstanding. Great to be here.
So let's get right into it and start at the top with neuropathy. What is neuropathy?
Well, neuropathy is essentially a disease of the nerves, and it can be motor, it can be sensory. And when I was in medical school, I guess 25 years ago, we were told that it's essentially progressive. There's nothing you can do about it, and it was going to degenerate, and that was it. And your job as a physician was to maybe mitigate some of the pain, some of the discomfort, some of the symptoms, but it was progressive, and that was it.
It's not a very good outlook.
No, and there's lots of reasons, obviously, why you can have neuropathy. It can be, and whether it's polyneuropathy or mononeuropathy, there's kind of different approaches to it, but it can be anything from nerve compression to diabetes to idiopathic, which means we just didn't figure it out. It can be Lyme disease. It can be any number of neurodegenerative diseases that cause this. But what it really is it's destruction of the nerve. And somehow the nerve is injured. So if you want to look at a nuts and bolts reason for this, it can be any host of diseases. It doesn't matter what it is. It can be a toxin. It can be a compression. It can be trauma. It can be, again, diabetes with advanced glycation end products, which is a result of having a high blood sugar. What they do is they coat the nerves and they cause inflammation. The inflammation causes damage or fibrosis, and then you end up with bad signals coming to the body. Either loss of signal or bad signals, which can be pain, heat, what have you, which essentially torture the person. And that's why neuropathy is so miserable.
And so can neuropathy present as both a lack of feeling as well as too much feeling, like painful, torturous sensations?
Usually it's a hybrid of the two. So neuropathy, whenever there's a nerve damage, people will have some loss of sensation, but then they'll get strange bad signals coming back to the body, whether it's heat, cold, or pain. So you might not feel anything, but you still have pain, which seems counterintuitive. Mm-hmm. You may not actually feel anything other than you have this crazy pain sensation coming back to you.
And so what's happening in those nerves, so if we're talking about, let's say, peripheral neuropathy, like in your feet, is it something that you feel all the time, something that can be worse with walking or pressure?
So the answer is yes to all of the above. There's, it's a very complex situation, and you're looking at all these tiny little nerve fibers having damage, and some of them will be sensory, some of them will be motor, but you can have any combination thereof. And again, any kind of disease that attacks the nerves, even Lyme disease, is notorious for causing certain neuropathies.
And can you talk a little bit about our nervous system in general? Like what's central, what's peripheral? What do they contain?
The central nervous system is the brain and the spinal cord, which is essentially the center of everything. Mm-hmm. Once you exit that, you have motor neurons and you have sensory neurons, and they all come out of the spinal cord typically, or the base of the brain. And you have the cranial nerves, obviously, and then you end up having the more peripheral nerves. And the peripheral nerves are much more vulnerable than the central nervous system to damage.
Okay. And I think probably most people have that image of, like, when they look, if you look at a person as just their nervous system, it looks a lot like a plant with roots, right? With, like, as they get further and further from the base of the plant, they become smaller and smaller rootlets, right? So, and those little rootlets are more vulnerable to damage, just like our are the distal aspects of our peripheral nervous system. Is that right?
Especially the longer they are. So coming out of your spinal column is going to be the nerves that innervate your toes. So the longer the nerve, the more susceptible it is to damage. So that's why we tend to see peripheral neuropathy start in the feet.
And you talked a little bit about mononeuropathy versus polyneuropathy. Can you talk a little bit about what differentiates those two?
Sure. One thing that I always think about with mononeuropathy versus polyneuropathy is if you have, say, neuropathy in this area of your hand, right?
Mm-hmm. So you're pointing to like the like by your pinky finger or your palm.
Sure, or just in your palm, anywhere, whether it's this area or this area, then that usually points to a disease process where a nerve is pinched somewhere.
Okay.
So it's you really need to rule out something that's mechanical with nerve conduction studies, et cetera. So one of the very common ones is having your ulnar nerve compressed in your elbow, and then you get neuropathy in your fingers over here. So that is actually something that is mechanical and is very easily fixed by taking the compressed ulnar nerve out of the ulnar groove in the elbow and transposing it and freeing it up and letting it breathe, so to speak. That's the important thing. A mononeuropathy, you want to look at a mechanical cause for that being compressed.
Okay. So like a thoracic outlet syndrome, or, you can have, or even carpal tunnel, you've got one area where it's being pinched off by something above it that's mechanical. And that cause of compression can be either injury or overuse or underuse or misuse. Can it also be systemic? Can you have like a systemic inflammation that causes a compression higher up and then ends up with a mononeuropathy?
Well, it would still be more like polyneuropathy. So something like gigantism or an oversecretion of HGH, you're going to have narrowing of the carpal tunnels, but it'll be on both sides. Okay. So you'll still have, a polyneuropathy. You'll have at least, it's symmetric rather than just one. So whenever you're looking at one spot, just on one isolated spot in the body, it's pretty common that it's going to be some sort of damage that's physical as opposed to metabolic.
Okay, so that's our first thing we need to think about if we've got a neuropathy is this an anatomical compression, or is this a systemic? And of course, the patients, if you're listening to this podcast for Healing Neurology, you are well aware that our clinic really specializes in systemic inflammation. So let's start talking a little bit more about that polyneuropathy piece. How does that present? What does that look like? If it's not just one area, is it always symmetric? Can you have a variety of areas?
So a lot of it's rarely completely symmetric. You'll usually have one side a little worse than the other, but you will have a component on both sides. And there's so many different reasons. And again, they can still be mechanical. It can be compression in the nerve roots in the low back. You can have metabolic disorders. Probably the most common cause, though, is going to be diabetes. And with lack of control in your glucose, you end up having damage to the nerves from the advanced glycation end products, or AGEs, which is kind of makes your body age or your nerves age, and it causes damage to them through inflammation. And the nerves end up not being able to repair themselves. And you can think of them as either dying of old age or damage. They just can't heal themselves. Another thing is also toxins. So we were at the conference in Vegas just recently, and you heard about fluoride as well as other toxins that can damage the endoneurium, the inner lining of the nerves, which then causes all sorts of different neuropathy. So toxins are another thing.
And medications can be toxins, is that right?
Absolutely. Fluoride and fluoroquinolones in some people is extremely sensitive, as we learned from the conference. So really neat stuff. And I'm sure there's a role for chelation and detoxification for a lot of these different either heavy metals or different ions like fluoride, and then allowing the nerves to repair themselves.
Mm-hmm. Do you work with fluoride-driven neuropathy?
I myself don't. So we typically, I'm more of a stem cell guy. So we look at how the body's going to repair itself. We try and coordinate with the underlying cause of the neuropathy. So especially if it's diabetes or anything like that, we really try and work with that. But I'll give you an example. Like I myself, I have chronic Lyme disease, stage 4 Lyme disease. And I actually had a sensory neuropathy where I had constant chest pain due to Lyme disease affecting my heart. And that was just constant. And the only way you can treat that is by trying to kill off the Lyme disease. The problem is Lyme disease is rarely completely eradicated, especially when it's stage 4, because it's living in the nerves. So you're having the nerves constantly attacked by the Lyme disease organism, and you can be on doxycycline for the rest of your life. It's partially suppressive, but it's still smoldering in there. There's nothing you can do, so you can't completely eradicate it. So what do? Well, you try and keep it at bay, but then we try and repair it, ideally with stem cells.
Let me just kind of summarize what we've talked about so far in terms of causes. Causes can be obviously anatomic or mechanical or compression oriented. They can also be systemic in terms of toxins such as medications or heavy metals or minerals or ions like fluoride. It can be
lots of medications. Lots of medications, especially with HIV. And cancer chemotherapy.
Chemotherapy medications. You can have alcohol is a really common cause for neuropathies. HIV/AIDS disease can be a cause. Autoimmune disease, vitamin deficiencies. Is that right? Vitamin
Absolutely.
deficiency or excesses, even with B12, folate, and B6.
Correct. Which we see in alcoholism as well. So they tend to get vitamin deficient. So it's a combination there typically.
And then other environmental toxins, so hexanes and environmental toxicities, pesticides and herbicides can also cause, is that right?
Absolutely. And these are all things that cause nerve damage. The common element is nerve damage.
It always surprises me how much people don't directly think about the fact that our pesticides and herbicides were designed as chemical warfare in World War I, right? So, and then we looked for a commercial use for all of these new chemical inventions. And so then we just laid them over all our crops, and then we can't figure out why all the bees are dying.
Exactly. And the way they killed those pests is by affecting their nervous system.
Just like they affect our nervous system and our children's developing nervous system. So really important to think about, especially in this, hot, sunny summer gardening weather. So please find other ways to take care of your gardens that they're at home.
And one of the big ones is also fluoride, and that's in our water and it's in our toothpaste. So, maybe you want to pick a fluoride-free toothpaste and make sure your water is filtered or goes through an alkaline water filter where it actually pulls out some of the fluoride. So a lot of these things are not, certainly if you have neuropathy, you may want to think about getting fluoride out of your water and out of your toothpaste because it may actually be doing more harm than good.
And there's a lot of things in our system that are also in our world that are also mitochondrial toxins. And mitochondrial disease can also be a cause for neuropathy, correct?
Correct.
Okay. So, and then the autoimmune disease, porphyria is another cause. And then we've also got environmental mechanical damage like vibration, prolonged cold exposure, hypoxemia.
Frostbite, certainly thermal burns, etc. And again, you're talking about damage to the nerve. It's whether it's a toxin, inflammation, or mechanical damage. It all boils down to damage to the nerve.
Damage to the nerve, infection, Lyme disease, damage to the nerve, virus, damage to the nerve. Yep. And we're seeing a lot of that post-COVID.
Correct. And, we have anosmia, so people can't smell with COVID. And again, you can look at that as a neuropathy where, there's the olfactory nerve is being damaged, so people can't smell anything. Then they have strange smells afterwards. So they may not have pain, but you're still looking at a sensory neuropathy where, it's just not right. And there's certain things that people just can't smell post-COVID. And some things are altered. So, they may is something that they used to smell to them one way is now smelling different. So it's still a neuropathy.
It's right, a nasal neuropathy. I didn't think about it in those terms, but that's what it is, a nasal neuropathy. I have one long COVID patient. She may well listen to this, so I hope it's okay. I'm not giving any identified information about her, but she talked about how foods taste different. So her oatmeal would taste like moldy peaches. And It's amazing to think about how you really can't protect yourself from poisons if you can't distinguish if everything tastes like moldy peaches. You're never going to know if something actually is moldy or not. If you're eating something that is going to be bad for your system, poison your system, you just can't tell. It's fascinating.
Yeah,
So she would have her mother be her kind of taster. She would say, "Are you sure this doesn't taste moldy?" And someone would have to kind of taste her food. She can tell.
Yeah, and not to mention, you want your oatmeal to taste like oatmeal.
Yes. Yes. Oh, okay. So all these things, hypothyroidism, so abnormal thyroid activity, end-stage renal disease, all these things can also lead to neuropathy, even just having persistent chronic complex disease, right?
Correct.
So,
and like hypothyroidism causes a lot of edema, so it causes kind of more of a mechanical dysfunction to the nerves. Whereas end-stage renal disease, you have toxins like uremia in particular that is affecting your nerve conduction, and it's also a pro-inflammatory state. You also have calcium deposits and things like that, metastatic calcifications. So you can call it, whether it's metabolic or physical, you can sort it in your own brain however you want, still damage to the nerve.
Damage to the nerve. It goes back. Nasal neuropathy. I'm never going to forget that.
Yeah.
Okay, so then as we're doing our workup for neuropathy to try and figure out what's going on, which one of these is it, knowing that, and I was just looking this up in preparation for this podcast, 46% of neuropathies remain idiopathic. So, which means almost half the time, we still can't necessarily find a trigger or a cause.
And you know what? I look at that, a lot of it as, on us as the medical practitioners. Are we not looking deep enough? Are we lazy?
Yes.
Did we not listen to the patient? Did we not check deep enough? Or are we just, complacent in our own little brain and not looking at a wide enough differential? Lyme disease is probably one of the most underdiagnosed diseases in the United States. And it causes a lot of different neuropathic conditions. It's also very difficult to diagnose because once you're past the acute phase, the Western blot doesn't really pop up. So you may want to really strongly consider treating somebody for Lyme disease if they have a couple bands in their Western blot come up that are even lukewarm, because they shouldn't really be coming up.
Right.
But it may be a sign of chronic Lyme disease or stage 4 Lyme disease. And the big problem with stage 4 Lyme disease is you probably need to treat it for 2 years before you successfully, not necessarily completely eradicate, but bring down the level of inflammation in the nerves and really keep it at bay. So, there's a lot of different reasons. And the other reasons are going to be environmental, something like, maybe you're fluoride sensitive. And the fluoride in the water and the fluoride in your toothpaste could be causing your neuropathy, but we haven't checked. So a lot of that is kind of on us.
I agree. And you don't see a lot of conventional practitioners checking for heavy metals or doing provoked heavy metal testing, doing any additional Lyme testing, mycotoxin testing, all those components, even mast cell activation, looking at allergies and other environmental sensitivities. Porphyria, I just don't see it checked very commonly in conventional medicine.
And it's not, and part of it is because the way that modern medicine is right now, the practitioners have been really penalized for spending enough time with their patients, really getting all the information, and the way reimbursement is, and the way it is dealing with patients. We're really rewarded for seeing the most people per hour, as opposed to really spending the time and being a good detective. So, I hold the practitioners partially responsible for that, but at the same time, they have to be able to keep their lights on. So there's only so much time that the practitioners have with the patients. Yeah. So part of that also, I would say, a good partnership with your patients is asking them to bring in kind of all their thoughts on a piece of paper so it can be quickly reviewed. And maybe that'll trigger something in your head. Say, aha, well, maybe, when you notice this after you took this medication, maybe you have a fluoride sensitivity. Or if you notice this, it started for some reason, in the fall after you had a hunting trip, maybe it's Lyme disease. So, you just never quite know what it's going to be. But, that little clue as to when it started or how it started or something that made it worse will trigger something that allows that partnership to lead to a diagnosis.
Yes, absolutely. Very well said. This is a constant hazard of trying to practice medicine in an age where you don't have enough time to actually listen to the patient's story. So we want to. We've gotten around that in our practice, not taking insurance. So we can now spend as much time as we need and as patients feel like they need. And it seems like in the emergency room, I don't know how much you're able to do that, but I know it's not a patient every
Absolutely not.
None.
Yeah. No, we have to take all insurances. And unfortunately, it's like an assembly line. In my private practice with stem cells, we don't take insurance because you get what you pay for. And, we want to make sure we have that the patient has our undivided attention. And we really sit there and get a good history. And, it really is important to me as a practitioner, making sure that before I do something for a patient, that I have the best chance for this to be successful.
Absolutely. And a history is especially important with neuropathy because it is there are so many causes. You're basically looking for whatever's going to trigger a disease in the nervous system. And because there's also family history. So one thing we didn't touch on yet was just the hereditary neuropathies. So Charcot-Marie Tooth, and there are some other, even congenital mitochondrial disorders that can lead to neuropathy. So a family history is always important. Does anyone else in your family have a history of neuropathy, right?
Sure. And again, it's still the same thing. Something is a predisposition in the family history that leads to nerve damage across generations.
So now when you're evaluating a patient, when you're doing your physical exam, how do you do your physical exam for neuropathy?
It's just a standard physical exam. But the first thing that you really need to do is a good inspection. And especially with peripheral neuropathy in the lower extremities, you're going to start seeing some atrophy once it's more advanced, because it's not only sensory, it's also motor. So you want to look at what their legs and their feet look like, certainly if it's in the hands. And especially with carpal tunnel syndrome, you're going to see a lot of atrophy in the thenar area of the hand, and you can actually have it throughout. But, really that's a clue how advanced the neuropathy is. And then after that, it's a pinprick sensation, there's light touch sensation. And it's just a matter of poking and prodding and feeling the patient where they have the neuropathy. Part of it also is seeing if you can map out a dermatome. So once it's dermatomal, then maybe that neuropathy is closer to the spinal root and maybe somewhere around the facets in the spine. So if something really maps out in a dermatome, which is the area that you would feel something in an area on the body, then that gives you a clue that the issue may be in the wiring back up towards the spine. So it's just a matter of doing a detailed exam, but it's part of it is just taking the time to really look.
And then after looking, what are some of the labs that you might order to look at neuropathy?
Well, the biggie always is going to be looking at what their diabetes risk is and what their hemoglobin A1C is. So if somebody is undiagnosed as a diabetic and their hemoglobin A1C is 11, which is off the chart, then you pretty much, you have, in law enforcement, we call this a clue. So this is, that's kind of a biggie. So that means diabetes is really out of control. They have a lot of inflammation. They have advanced glycation end products. So the first thing you do is start treating the diabetes because you want to stop that inflammatory cascade. But then you need to kind of go into the history and get an idea of what you want to test for. Certainly heavy metal testing is something that you want to do. And you want to look at the different disease processes and just kind of do a really good panel that's in general. And when you see certain things that are abnormal, then you want to start looking and pulling that down or pulling it out. And some of the things you want to look at are hemochromatosis, looking at iron and ferritin levels and things like that. These are all very common things that can cause neuropathy. So, it's just a matter of really going down the checklist and saying, hey, all these different things cause neuropathy. Let me start pulling in what is a possibility. Absolutely. But a lot of times you just don't have anything pop up. So then you want to start looking at heavy metals and things like that.
So hemoglobin A1C, some of those vitamins we talked about, a B12, a B6, a folate, a B1, thiamine, a TSH to look at thyroid, an ANA to look at autoimmune activity, an SPEP, UPEP, which can look at risk for cancer or monoclonal gammopathy.
As far as autoimmune, you really need to do a full autoimmune panel. ANA is kind of very limited. So once you look at the basics and you don't get anything, then you want to jump into a full autoimmune panel. But the autoimmune panel has fairly low yield when you're looking at the first visit. So I typically do that as a secondary thing. It's extremely costly to the patient to do autoimmune panels. So only if we get nothing on the initial workup, do I really jump into the full autoimmune panel because it really is low yield and high cost to the patient.
Do you have a standard like full autoimmune panel that you order?
No, I do. I have to look it up. Part of it is you have to sit there. So in internal medicine, when I did my residency, my program director was a rheumatologist.
Oh.
And one thing I learned is that in rheumatology, not everything fits very nicely, but you have algorithms that you go through. So you really have to look at what your algorithms are. And I typically do a shotgun approach to my autoimmune panel and get it done once, and then see if you have anti-nuclear antibody or you have this or rheumatoid factor, and then you see what's positive and you put them together and you go down the algorithm. But it really is an algorithm-driven diagnosis at that point.
So in some of those antibodies like anti-WHO or anti-GM1, you can find those more typically, or Sjogren's.
And Sjogren's is one of those things that you're going to really pick up by history, with different ulcers in the mouth or this or that. Yeah, it's pretty interesting. It's part of taking a good history, and that'll lead you to it pretty commonly.
And then there's some other things we can look at for neuropathy, right? We can do lumbar punctures or skin biopsies or autonomic testing for small fiber neuropathy or EMGs. Is that right?
Exactly. Yeah, and the EMGs are actually very important. We don't do EMGs in our practice. We refer out for EMGs, but especially if you're looking at mechanical compression and things like that, the EMGs are very useful. And a lot of times I really get the patients who've already been diagnosed with neuropathy and they've failed most of the treatments. So I would say maybe 1 in 10 or 1 in 15, I'm actually diagnosing. And because we're actually having success in, getting people better, I'm actually doing more treatment than diagnosis these days.
So let's dive into treatments.
Sure.
So how do you think about treatments for neuropathy?
So one of the things I like to do for neuropathy is I certainly like to make sure that the patient has strict control of whatever is causing their neuropathy. So if you are lucky enough to not have idiopathic peripheral neuropathy or any kind of idiopathic neuropathy, you want to treat the underlying cause. So most common is going to be diabetes, right? So strict control of diabetes, the hemoglobin A1C, that's kind of a big deal. And you want to make sure that, whatever your underlying cause is, that you're really, you're treating it. So if you have something like a toxin-induced neuropathy, you want to look at NAD treatments. You may want to look at glutathione treatments and chelation therapy to get rid of some toxins. And that's certainly something that can help with the inflammation. But typically we use biologics to help repair the nerve tissue. And that's what we do. I'm not a big fan of Neurontin or any of the medications people use, all the antidepressants, because historically they really don't work.
If you haven't taken care of the root cause, then you're going to end up with more and more, and then you'll just have it breaking through the neurontin, the gabapentin.
And a lot of it can also just be a pro-inflammatory state. So there's a lot of different things that we can do. And again, the biologics that we use really are aimed at stopping the vicious cycle of inflammation and damage. So I typically use 3 or 4 different things to repair the nerves, and we're seeing actually really good results. And it all started with some papers that I read about peripheral neuropathy and PRP injections.
Talk to us about PRP.
Sure. So PRP is very simply platelet-rich plasma. It has all the healing factors of your body. So say you get injured, you have bleeding around the site of injury. You can call it a bruise, hematoma, whatever you have. But what ends up happening is the heme from your blood causes additional inflammation. And in your blood, in the platelets and in the plasma are all the healing factors. They're anti-inflammatory. They call stem cells to start migrating, homing, and differentiating into healing tissue. A lot of it is fibrotic, but a lot of it is very anti-inflammatory. So in platelet-rich plasma, we're separating the inflammatory factors from the anti-inflammatory and growth factors, and we're injecting that around the nerves. And those papers that we read, I was saying to myself, this might help some of my patients. So we tried it. And of course, the mad scientist that I am, I had to do it. So we didn't charge our patients initially to do it because we didn't know if it would work. There's a lot of papers out there that could be wives' tales or whatnot. So we said, let's just try it. Well, shocker, it worked. It really worked.
Wow.
So we just started doing it on a regular basis, and patients were getting better. The problem is, again, a lot of these people were idiopathic, so you don't know why it worked because you don't know what the underlying cause is. But we figured out if you do it every 6 months to a year, they're not getting worse, and they may even be getting better and getting some of their feeling back.
Mm-hmm.
So, there's hope even if you don't know exactly what it is. It's just a matter of putting those factors in there and letting the body heal.
And so where are you injecting them?
So around the nerve, where same place you would do nerve blocks if you were an anesthesiologist, a regional anesthesia, if somebody had to do surgery there or work on the body. What you do is you figure out where the nerve comes out, and either via ultrasound or if you know the anatomy, you can inject around the nerve and it goes to work. Amazing. It's really stupidly simple.
And PRP you harvest, how do you harvest PRP?
So you draw some blood out of the patient's arm, you spin it down, typically for about 3 to 5 minutes, the most is 8 minutes. And you just pull out the golden stuff that left behind by the red and inject that where you want to.
So, and you said you had 3 or 4 treatments that you use. What else do you use besides PRP?
Sure. So if somebody's very inflammatory, what we're seeing in joints and perinaturally, there's a bunch of papers on this. It's called fibronectin aggregant product, so FAC. And what that is it's extremely inflammatory, and it causes a vicious cascade of inflammation and damage. So what happens is our body produces a protein called alpha-2 macroglobulin, which is very common, when we're kids and when we're young adults. But as we get older, our body produces less and less alpha-2 macroglobulin. So alpha-2 macroglobulin can be purchased commercially, and it can also be made from our peripheral blood via certain processes. We've done it in the past where we take it out of people's peripheral blood through a process and force the body to make its own, so to speak, alpha-2 macroglobulin. And then we inject it back into that area in a mix of PRP. And then that neutralizes those proteins that cause that vicious cycle. It also works very well in joints. So that has a lot of promise. And again, we're learning more. There's more research being done about this. Then there's exosomes, which can be used for neuropathy. Now, exosomes will stimulate typically healing and repair, as well as stem cells in that area to wake up and start repairing and differentiating. Now, the problem with exosomes is you have to get them from a very reputable source. You have to know what you're getting. There's a lot of exosomes that are commercially available. We can't make the exosomes in the office ourselves. They're all essentially purchased commercially. But you have to make sure you know what you're getting, and you're getting exosomes, which are messenger RNA, little globules that are anti-inflammatory and repair, not just exosomes taken from a placenta someplace, because you don't really know what you're getting.
And what dose of exosomes do you use if you're doing injections?
So if we're going to stick needles into people, I recommend that we put a big dose in. So we probably do 15 billion exosomes per treatment.
Per treatment. And then what's your frequency or your interval between treatments?
So it depends how bad the neuropathy is. So if somebody has mild neuropathy, we can typically just do one treatment, and then we'll treat them once a year to make sure it's not getting any worse. But if somebody has fairly bad neuropathy, then what I recommend is we hit it once, and then we hit it again at 6 weeks, and then we see how they do. 6 weeks in, it's good to hit it with a booster, and we get the best results when we do it at day 0 and then 6 weeks. And then we follow them out to like 3 months, 5 months, 6 months, see how they're doing. Maybe if they're really bad, maybe they need another treatment. But at some point, we'll get to a steady state, and then we just hit it once a year. And then, of course, stem cells.
Talk to us about stem cells.
So stem cells, we use your own stem cells. So I'm certified to do both bone marrow as well as adipose-derived autologous stem cells. And what we do is we can either aspirate bone marrow, or we can aspirate fat, and we can remove the fat and break up the intracellular matrix with a collagenase, which we call liberase, and it frees the fat cells from the stem cells and pericytes, etc. We spin it down and we pull out essentially the stem cells after we wash out the enzymatic scalpel that we use. And stem cells are your own healing cells. So the ones we use are called mesenchymal stem cells, whether it's bone marrow or from adipose. and they're your own cells. And by dumb luck, they're trapped in your body. So the most common stem cell that we have is bone marrow stem cell. They're circulating in very high numbers until you're about age 25, and then they very rapidly kind of decrease per year. And, the way I think about aging is not just a normal process where you're wearing out your parts. It's an inability for you to actually repair your parts because of lack of stem cells. So aging is not a wear and tear, it's a lack of repair. So what we do is we cheat. So we either go into the bone marrow and rip out a whole bunch of stem cells with a syringe, or we go to the adipose, which is fat, go to your love handles, we steal those, we get a whole bunch of stem cells. And by dumb luck, your fat cells, or around the fat cells, is this matrix where all these stem cells are, and they're just stuck. They're doing absolutely nothing. And I think the number we were looking at is there's about 400,000 stem cells per cc of fat trapped.
Wow. So
the literature that's out there, you can see, everyone can search it for themselves. There's a lot more literature coming out as we speak every year. There's about 400,000 stem cells per cc of fat. And what we've seen is that the fat-derived stem cells grow as well in culture as umbilical cord cells, whereas bone marrow, it grows more slowly the older we get because they're older and they're not as good. So even though I'm certified to do both, I do mostly fat because our patients do better. And when you look at how they feel afterwards, the ones that get the fat, they respond more quickly and more completely. So again, remember, you're talking about nerve damage. So how do we heal the nerves? Well, we want to stop what's causing the damage, but then we want to put in the cells that actually heal it. So that's where the stem cells come in. So, and we do the same thing. We go around the nerve where it is, same place that you would put the PRP or the exosomes or alpha-2 macroglobulin. And you can even combine the therapies if you want to do a shotgun approach. But certainly with alpha-2 macroglobulin, the way I do it is I will pre-treat the area 2 weeks earlier with alpha-2 macroglobulin to neutralize the toxins that are in there, or not the toxins, but the inflammatory proteins. And then 2 weeks later, after the process is finished, that's when we introduce the stem cells to go in there and repair the damage. So that's kind of the big two-stepper.
How do you decide between alpha-2 macroglobulin, exosomes, PRP, and stem cells? Like, how do you decide beyond kind of what you just mentioned about the alpha-2 and then 2 weeks later stem cells? How do you decide if and when to add in the PRP or the exosomes?
So doing the two-step process, it's kind of the more severe the neuropathy is, the more far gone they are, the harder we'll hit it. So if somebody has very severe neuropathy, what I'll recommend, because we know it exists, that you can do in joints, you can actually do an FAC, a fibronectin aggregatin complex test in the joint fluid, but you're not going to be able to get that out of a nerve. But we do know that exists. So, and I'm not going to biopsy the nerve or anything like that. So what we're going to do is if somebody has really severe neuropathy, I may say, hey, in you in particular, because of your history, and this has been going on for so long and it's so severe, why don't we do a alpha-2 macroglobulin pre-treatment, and then we can hit it with stem cells afterwards. Now, stem cells, the way we do it, initially, we do typically the stromovascular fraction treatment, which is a surgical procedure. Again, we do a liposuction, we pull out the fat, we use the enzymatic scalpel to free the cells, and then we introduce that in part of the same surgery back into the body, and we'll do perineural injections with the stromovascular fraction. The stromovascular fraction is not just stem cells alone. It's a mix of different cells, it's pericytes, etc., and it has a lot of healing factors in there. So this amazing little soup of cells and growth factors really does a great job. What we typically also do is when we do the harvest, we will send cells over to a stem cell bank that is CGMP approved, where they can be grown as an individual cell line for that person, and they can be expanded. And when we bring those cells back, when I do a peripheral neuropathy treatment, I will combine those mesenchymal stem cells that we receive back from the bank with PRP. It helps activate them. it puts them in a scaffolding that keeps them in the area.
Mm-hmm.
And it also has those healing and growth factors that activate the stem cells.
Mm-hmm.
So that works really well. So typically, I used to do PRP alone, but the people who come to me, most of them have fairly advanced neuropathy. And we've just found that the PRP helps with the inflammation and some of the repair. But unless you get those stem cells in there, whether it's SVF or expanded mesenchymal stem cells, it's harder to repair the damage to the actual nerves. And nerves grow very slowly. So we want to do as much as we can to help that.
So the PRP are kind of like little nannies for the stem cells.
They're nannies. They're cheerleaders, as well.
Go, baby, go, baby, go.
Pretty much it. They're motivational speakers, whatever you want to call it. And they provide some of the signals that tell the stem cells what to do. It's like having Rice Krispies put into a bowl, but until you add the milk to them, they don't make any noise.
Even doing stem cells systemically, we do a lot of that in our clinic, IV stem cells, for systemic issues, that the exosomes that we harvest out of that stromal vascular fraction, people will often feel an immediate boost of feeling better in the first 3 to 4 weeks. And that
you feel like a superhero.
Yeah. And that's not really the stem cells necessarily, because those can take, they'll find their spot within the first couple of weeks where they're going to be and where they're going to grow, but it's going to take a couple of months to really grow them out and have them do their job. So
it's like growing a baby.
Uh-huh. Yeah.
Yeah. All those healing factors are just amazing. And, again, we have a lot more of that stuff going on when we're younger, but as we get older, after 30, it's really diminished.
So this is fantastic. Okay, so basically in neuropathy, we've talked about what neuropathy is, what it feels like, that it can be divided into those categories of sensory or motor, that it can be divided into those categories of central versus peripheral. I loved how you mentioned about even, like, I'm doing air quotes around peripheral, can be central in origin, right? So you can have small fiber neuropathy around your gut. So you can have gut dysfunction and dysautonomia, but it can still be considered a peripheral neuropathy. Peripheral doesn't just mean hands and feet, although that's what we think of it. You can have those little rootlets, the ends of those nerve rootlets that are in your torso, in your back, in other places.
Sure. And like with my Lyme disease, I had horrible constant chest pain, which was neuropathic chest pain. And with regular IV infusions of stem cells, I don't have any chest pain anymore.
That's amazing.
And interestingly enough, I also had a conduction block. Still have one, but it was a very severe trifascicular block. And my QRS duration was about 200 milliseconds a year ago. And, I'm looking at a pacemaker and all this stuff, thanks to Lyme disease. And we just did an EKG. When was it? Oh, last night. And my QRS duration is now 180.
Oh, wow.
So that's significant. That's a big difference.
That's a big improvement.
We don't see it go backwards.
Right.
Like ever. So
that's amazing.
The thing I love about stem cells is, every month I see something that they told me in medical school was impossible.
How long have you been doing treatments on yourself?
So I've been doing 40 million stem cells every 3 months aggressively for about a year and a half now. And it took about a year really for it to kick in with my heart, but it kicked in. And part of it is because I have Lyme disease. And, even though I'm on and off on antibiotics, kind of cycling it so that I at least have some gut flora left, what ends up happening is it's like having a forest fire and planting trees at the same time. So some of the trees burn up, some of them live. So it's really an uphill battle. And you'll see that with like rheumatoid arthritis and autoimmune diseases. So Lyme disease is much like an autoimmune disease where you have to continue to add in new cells, but I am gaining ground on myself as well as my patients.
Wonderful.
But again, it's a cardiac neuropathy. You can think of conduction delay as a cardiac neuropathy as well.
We were working with a vascular surgeon on the East Coast who does celiac plexus blocks. So that's the nerve center of your gut, and finds that it cures 50% of dysautonomias.
Yeah.
So these things are so tightly connected, these systems in our body. The communication of cells in our body can't be overstated, how much the whole system has to work together.
It really does. And, as we get older, things wear out, they get damaged. And if you can't repair them, they're going to be causing you problems, either pain or problems. So, we're just looking at ways to let the body actually repair itself. When we're 20, 25, we don't have any of these problems typically. We're completely invincible. And that's because we have stem cells, we make alpha-2 microglobulin, we make all these different things, and we don't really know why all this stuff works yet. This is kind of a new era in medicine that we're just discovering. And our PhDs I think are going to take a long time to teach us why these things work. But again, we had the steam engine locomotive, moving coast to coast long before we understood thermodynamics. So this is another example of that. We're seeing really a new era in medicine where we're able to reintroduce these cells, but it's going to be a while before we truly understand the exact mechanisms by which they work.
In my experience, I started out getting interested in medicine through Ayurveda, traditional medical system of India. And so a lot of the concepts that I was trained in Ayurveda are now coming to the forefront in Western medicine. So it's exciting to see the science behind these ancient philosophies and understandings. And I will say that Ayurveda, Ayu means life and Veda means science. So it's really the science of life. And it is a very scientific system, but of course, not in the same way that a laboratory is scientific. And so it's fun to watch these two worlds get closer and closer together as time goes on.
Well, and I think we're always humbled the more we learn about this, that the body itself knows how to repair itself way better than we do.
Yes.
So anything we can do to set the body up for healing is the best medicine.
Well, anything else you'd like to add?
That's really about it. I mean, the first thing I would just really add is if you're frustrated and you're suffering with neuropathy, there is hope. You don't have to give up. It's not always in a box of pills or a jar of pills that's going to be your salvation. Yeah. Those medications can help. If you have to go through chemotherapy or something like that to kill a cancer and you end up with neuropathy, we have ways to help you heal. It's not just a sentence to misery or a death sentence. So we are still learning. New things are coming out, and we have about 80% success rate in getting people better through one of the different techniques. So, don't give up hope. And as we teach other people to do that, it's going to be available coast to coast. But we're always available in California if you want to come out to us, and we can give you a hand too. But you're not alone. And, all of us as physicians want to help you. So I hope we learn more and more every year. And it's not just giving you a pill. We can actually let your body heal itself.
Can you tell us the name of your clinic where folks can find you?
You can actually go to stemcellrevolution.com. I work with the California Stem Cell Treatment Center in Rancho Mirage, California, with Dr. Lander and Dr. Berman. And because I'm an ER doc, I'm kind of the needle guy. I can stick needles into pretty much anywhere you have on the body with either fluoroscopy or ultrasound, and make sure that the payload gets to where it needs to be. But the bottom line is we've helped thousands of people, and you're not alone. So hopefully we can help you, or one of our affiliates can help you and get you better.
Thank you for all the work that you're doing. And we met at that stem cell conference, cell surgical conference in Las Vegas, which is why I'm having you on today. And with what the data that you were showing us and your experience in clinic, Dr. Ruhoy, our neurologist, has been doing nerve blocks and nerve injections for, I think, decades now. I don't want to date her, but so we're going to start doing those with stem cells, so we can harvest stem cells and then use that as we've always done with PRP and other substances. So
sure. Yeah. And I would recommend again, day 0 and then 6 weeks, and then see how they are between 3 and 6 months. And most people respond. It's really cool.
Great.
Outstanding.
Well, thank you, Dr. Olesnicky. It's been wonderful to have you. And thank you all for listening with Dr. Olesnicky. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can get more information about him and his clinic at stemcellrevolution.com, or about us at our website, centerforhealingneurology.com. Please be sure to share this show with your friends, and we welcome your rating and review wherever you get your podcasts. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and see you next time.
Fish Media.
Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.